welcome everybody to this webinar with the Mental Health Association in Michigan. My name is Marianne Huff, and I am the president and CEO of the Mental Health Association in Michigan. And it's nice to see so many folks in attendance today. The topic that we're talking about is Mental Health Advocacy 101, and it's a topic that's near and dear to my heart because it's what I've done in my career for many years. Has been a mental health and also an overall disability rights advocate for a very long time. And it's one of the core things that the Mental Health Association in Michigan does is advocacy and, of course, public policy work, primarily at the state and local level in Michigan. A lot of the work that I do within the Mental Health Association in Michigan concerns itself with mental health advocacy, both systems work, which we're going to talk about today a little bit, and individual advocacy, which are two different things. My history is that I have done a lot of different things sort of in and around the community mental health world in Michigan. I was a case manager for a CMH in the 90s where I worked with adults with serious mental health conditions, and I did a lot of housing work that was for Oakland County. I worked for Disability Rights Michigan, which when I was there was called Michigan Protection and Advocacy Service. And a lot of the work I did was helping individuals and families access CMH services. Also did a fair amount of abuse and neglect and death investigations in state psychiatric hospitals, nursing homes, and adult foster care homes as part of what was called the CARE team. I've done disability rights work for Center for Independent Living in Ohio. I've been a CMH director, and now I am the head of this organization, the Mental Health Association Michigan. Just a big, want to put in a plug for this association, which was founded in 1936 and was incorporated in 1937. So depending on how you look at it, we've been around for 90 years. We are an affiliate of Mental Health America, which is the national organization, which was founded by Clifford Beers in 1909. When he wrote his book, A Mind That Found Itself. And originally, when the Mental Health Association was founded at the national level, it was all about improving conditions for individuals with mental health conditions and substance use disorders that were in what we called at the time asylums or psychiatric hospitals. Mr. Beers, Clifford Beers, was a Wall Street stockbroker that had a couple of nervous breakdowns after one of his brothers became ill, and he was in about 3 or 4 different psychiatric asylums. 2 were public, 2 were private, and he describes the conditions in his book, A Mind That Found Itself, which you can find online. Out of that came the National Mental Health Association, which he founded with the well-known psychologist William James. So those of you that are in the human services profession, social work, psychology, have heard of William James. When MHAM was founded in 1936, we were called the Michigan Society for Mental Hygiene, and our focus was primarily on psychiatric hospitals because back then there wasn't really any treatment for mental health conditions. Pretty basic and sometimes abusive. So that's a little bit about us. In 2026, what we do is we pay a lot of attention to what's going on in the legislature, the Michigan legislature. We look at mental health legislation that's being introduced, or if we become aware of legislation that's being worked on, we pay attention to that. We pay attention to and monitor any changes in mental health public policy that could be coming from the Michigan Department of Health and Human Services or other departments within the state of Michigan. Our goal is to make sure that anybody in Michigan, regardless of severity of condition or regardless of how old the individual is, whether they're an adult or a child or an adolescent, that they have access to quality mental health and substance use disorder services and supports. That is our goal. So as I said earlier, if you have questions, you can put them in the chat, but also I'll reserve time for questions and answers. This session is 1.5 CEs for social work and McBat. So we will be going until 2:30 this afternoon. And I will give everybody a 5-minute break around 2:05 so you can get up and stretch and do what you need to do. But again, appreciate you being here. We are a 501c3 nonprofit, and we do not take any government funding. We don't take state dollars. We don't take federal dollars. We are funded through donations from folks like yourselves. We are funded through memberships, and we are funded with the gracious support of the Flynn Foundation and the Carl Gerstacker Foundation and others like the Sage Foundation. This is going to be a presentation that's going to talk about mental health advocacy, primarily focusing on the community mental health system in our state. So a lot of you have probably heard this quote from Margaret Mead, where she says, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has." And I believe that. I believe that people can change the world, make the world better. There's lots of stories out there, things that I've heard about and I've experienced where it didn't take that many people to improve things for other individuals. A good example is Clifford Beers and his work. A Mind That Found Itself, his story had a profound effect on mental health public policy in the United States. And it actually helped create, was one of the drivers behind the National Institute of Mental Health and other public policy decisions that came about at the federal level. So let's talk a little bit about what is advocacy. And advocacy is basically speaking up on behalf of another or on behalf of oneself. In mental health advocacy, one of the main goals that we have, depending on what the issue is to make sure that the other person's interests and rights are protected and preserved. And that's really what governs advocacy in my mind. And advocacy has been something that's been necessary for probably more than hundreds of years, more like thousands of years. For those of us who consider ourselves to be disability rights advocates, our interest is in either speaking with and on behalf of an individual with a disability if they cannot do so themselves, or helping them navigate the process. And I've done both in my work. I've advocated for individuals who did not have the ability to speak, but who communicated in other means. I've advocated for families who have children or are the guardian of a person who's considered to be legally incapacitated and needing services in the system. So advocacy has many forms. One of the other things is we want to bring social problems and injustices to the awareness of the public, but also policymakers. We want to ensure social justice, and we always want to be working towards social change. The work doesn't end. And you know, I often say that one of my goals as a mental health advocate is to put myself out of business. If I put myself out of business, it's because there's nothing to advocate for anymore because things are working really, really well. The interesting comment or observation I want to make about systems, especially because I've been in and around the public mental health system for over 35 years in some way, shape, or form, not just working in the system and being an advocate, but I had a younger brother who was in the system in assertive community treatment for many years, and I was my brother's guardian. I also had other loved ones and family members. So the only thing I have not been is a primary consumer in the system, but I've been a secondary consumer. Is that the system, back when it started in 1963, it had a real noble cause. It still does. But what can happen with any system, it's not just the community mental health system, it can be any system. Sometimes systems evolve to the point where they need to be reminded of what their original intent was. And sometimes I think the role of advocates is to be the conscience and to say, we realize you have a lot of rules. I mean, community mental health, just like any other system, whether it be the overall Michigan Department of Health and Human Services, Medicaid, food stamps, TANF, Social Security, they're overburdened with a lot of administrative rules. And I think sometimes the focus becomes on the administrative rules and the regulations, and the original intention, which was to help people, can get lost. This is a picture of Civil Rights March. Some of you, and I'm not going to go into a lot of detail, but if you're interested, in the 60s, we had quite a few movements happening. We had the women's rights movement, we had the war on poverty, we had the welfare rights movement, but we also had the disability rights movement that actually began in 1968 and intensified in the 70s. And I want to make sure that I acknowledge that, because I think sometimes that gets lost, that we had the disability rights movement. So we had a lot of efforts on the part of individuals who had been disenfranchised, sort of, held down, whether it be women, people with disabilities, people of color, people of lower socioeconomic status, speaking up for themselves, which was all a very, very good thing. But I think what's lesser known is the disability rights movements. What got us to 1990, when we had the signage in July of 1990 of the Americans with Disabilities Act. And even before that, when Section 504 of the Rehab Act of 1973, when there were no regulations promulgated, we can talk a little bit about that later, how that happened, that a lot of people with disabilities protested across the country, primarily in San Francisco. And that forced the United States Department of Health, Education, and Welfare, which we don't have anymore, to promulgate rules enforcing 504. So I kind of got ahead of myself. So examples of advocacy. I was talking about the month-long sit-in that occurred in the early 70s to force the Secretary Joseph Califano of the Department of Health, Education, and Welfare to create regulations to enforce Section 504 of the Rehab Act. You can find it on YouTube. It's by Breif, which is the Disability Rights Education Defense Fund. They're in California. They have a great video about 504. And you'll see, if you're familiar with disability rights, some of the heroes are Ed Roberts, Nancy Human, and others who were sort of the founders of the disability rights movement. Actually, Roberts and Human were instrumental in the creation of the Centers for Independent Living in the 70s. This is a historic moment from ADAPT. If you're not familiar with who ADAPT is, ADAPT began in the 70s, and it was all about transportation in the beginning, because when veterans were coming back from Vietnam, they found that transportation was not accessible to them. A lot of them had wheelchairs because they had significant injuries while they were fighting the battles in Vietnam, whether they be amputees, paraplegics, quadriplegics. They could not get on buses, and so ADAPT started with civil disobedience. When I worked for the Ability Center of Greater Toledo for 3 years, I was the director of advocacy. I was able to participate in 2 ADAPT actions, one in Chicago and one in Washington, D.C. And that was a rather interesting experience, going to the Capitol and going to the office of who was then Representative Congressman Barney Frank, the head of appropriations. So what you're going to learn in this system is what are some of the tools that you need to navigate the community mental health system Why is the ability to speak up vital? And why should family members, and of course, I know we have professionals here, professionals, you can amend this language to include yourselves because a lot of times professionals, social workers, psychologists, counselors, psychologists, and others find themselves advocating for folks to get into, to receive services from the CMH system. And why is it important to have advocacy skills? I think they're important regardless of your discipline. So the two types of advocacy are individual advocacy, which is something that I do at MHAM. It's on a much more limited basis than when I was with Disability Rights Michigan, but when there's a significant situation with somebody and they've been unsuccessful in getting what they need, or they've not been able to get what they need for their loved one. I have gotten involved in those situations in the past. So then there's what's called systems advocacy, which is more of the work that we do at MHAM. Systems advocacy is when we identify an issue that could affect an entire group of individuals within a system. So a good example would be adults with serious mental health conditions. There's a suggested policy change that may be made by, right now, it would be the Michigan Department of Health and Human Services. If we thought that we determined that a change would be detrimental, we would be advocating that maybe that change not happen. Or if we thought something was good, we might be supporting it. I mean, it can take many shapes and forms. One of the issues that MHAM has been monitoring, which a lot of folks aren't aware of, is what's called the mental health framework, which has been proposed by the Michigan Department of Health and Human Services, which would be a big change both on the inpatient side for individuals with Medicaid and also the outpatient side for individuals with Medicaid. I'm not going to get into that now, but that's an example of systems advocacy. So when we do systems work, it could mean that we look for other groups that have similar concerns, and we work together to bring those concerns to the right people in the right positions, maybe within MDHHS. Other times it means going to members of the legislature and speaking with them about the concerns. I mean, systems advocacy is interesting. I know last year, when we've all been concerned about the proposed reductions in Medicaid, a lot of organizations like MHAM and others were writing letters to members of Congress expressing concerns about the reductions that were proposed to Medicaid at the federal level and how those would negatively affect individuals with mental health conditions and substance use disorders in our state. So that meant gathering a lot of data and information about what the impact would be, although at the time we weren't really clear on the impact, and I don't know that we have absolute clarity right now about what the impact is going to be. To be an effective advocate means knowing a lot about the system or program you're helping your family member or loved one to navigate or access, or if you're a professional. There's a lot to know when you're navigating programs like community mental health, Medicaid, Social Security. I remember being a case manager and having to know a lot about these different programs so that I knew how to help my clients navigate those systems. You also have to have good effective communication skills. And it takes a lot of self-awareness to be a good advocate. And I will say it can be difficult at times because it can be very frustrating when, as an advocate in my work, when I've been trying to resolve an issue or help somebody get services that I believe that they really need, and having to navigate a system that can sometimes be much more of a hindrance than a help. And systems can be very much that way. I spent a lot of time identifying policy changes that should be made, to make things easier to navigate. You also have to be able to navigate conflict, because if I've really come to terms with the fact that to be a good advocate means you have to be able to navigate conflict. I've also learned as an advocate that when an advocate like myself gets involved with a system or a particular entity, like maybe a CMH or a PHP, they're not always happy to see the advocate. And I don't mean that in a negative way towards them. It usually means that, we're challenging something, or we're helping the family or the individual challenge something. The term street level bureaucrat is one we'll talk about. That came from a writer about mental health public policy who looked at the people that do the work, that interface most with the client or the consumer, whatever term you want to use, as the person that has to communicate to the family or the individual the rules, the bureaucracy. And sometimes the person who is in the role of the street level bureaucrat, what comes to mind is a case manager or supports coordinator. They unfortunately take the brunt of the negativity when they're the communicator of policy that they didn't create. You also have to learn how to be calm, cool, and professional, even if the system within which you're working makes personal attacks against you. That, I thought a lot about putting that in here, but I've learned over the years that, humans are humans. And sometimes when you're an advocate, people take it personally when they really shouldn't, because it's not about them, but they do take it personally. And when that happens, things can get really foggy, because if someone's taking it personally and not objectively able to determine this person is only advocating with and on behalf of somebody who's trying to get services, it can become a lot more difficult to get what's needed. The flip side is it's important for families, professionals who are advocating for people to not take the actions of the system, or those who work in the system work really hard not to take it personally, because it can cloud your judgment. So being an advocate means you understand the difference between public policy and social welfare policy. You also understand that your loved one, family member, or your client, if you're a mental health or a professional, accessing programs that are created to address a social welfare problem. And so you have to have a basic understanding of these problems. The social welfare problem that I'm referencing here is that community mental health was created in 1963 because we had almost 500,000 people across the United States in these state psychiatric hospitals that were overcrowded, and not necessarily providing treatment, because this data comes from the 50s. We didn't really have treatment until 1952 when Thorazine was invented. The other thing about advocacy is being willing to put yourself out there, and being willing to subject yourself sometimes to really frustrating decisions. The bureaucracy, the rules that the bureaucracy has to follow can be very frustrating, and finding ways to still navigate these systems despite those barriers. So public policy is defined as general term for decision, laws, and regulations put forth by governing bodies. And social welfare policy is the organized response or lack of a response to a social issue or problem. So a good example of lack of a response to a social issue or problem from where I'm sitting is why so many people with mental illness continue to end up in jails and prisons, as opposed to getting psychiatric treatment that they need. I mean, that's not the subject of this conversation, but I've been asking myself that question a lot lately, as I'm getting more calls from families who call law enforcement because their loved one, child, loved one, friend is acting out of uncontrolled symptoms of a mental illness. Usually it's psychosis. And the person might say or do things that they would not normally do, which is typically what happens when somebody has a high degree of psychosis or emotional dysregulation. And when law enforcement arrives, the individual acts out of that. Of course, it's can't imagine what it would be like to have psychosis going on and then see people in uniforms come. When people act out of that, instead of taking people to an emergency room, they end up in a jail where they typically face charges for, maybe they resisted the officers, or, maybe they acted out in some way. We still have a lot of work to do on that, frankly. Examples of social welfare policy, of course, the Social Security Act of 1935, which has been amended many times. And, from the Social Security Act of 1935 comes Medicaid, comes Medicare. We didn't have Medicaid and Medicare until 1965. Other social welfare policies we've talked about, the ADA, the Rehab Act, and of course the Food Stamp Act of 1964. And here's the term street level bureaucrat. Again, these are line staff, case managers, supports coordinators, others who are responsible with implementing public policy at the client level. So as a good advocate, you have to learn how to interact with the street level bureaucrats to help your client or your loved one get what they need. And sometimes you may have to educate this person about the program they administer. I have found that a lot, that I'm not sure that when folks start working in the community mental health system that there's time or the ability to fully train them on different aspects of community mental health, which of course is a large bureaucracy with a lot of rules and regulations. But even basic things like knowing what is a Medicaid provider manual and what services are provided is not always known, which is why we try to do periodic trainings at MHAM on the community mental health system, and we'll talk a bit about that today, so that families and individuals and professionals who help people navigate that system know what is potentially available to individuals. Finally, good advocates understand one thing, and I learned this a long time ago. You follow the money. When I say you follow the money, you need to know, is the service or program or whatever you are advocating for or helping somebody try to access. It makes a difference if that program is paid for with federal dollars or if it's paid for with state dollars. Why is that? That's because one of the things advocates need to understand is what are the rights and responsibilities that the individual who's seeking these programs has to let the decision maker, i.e. could be the CMH, could be the PHP, could be the state of Michigan. How do they let them know that they disagree with the decision? If it's federal money, like Medicaid, for example, then an individual who's a Medicaid beneficiary has access to requesting an appeal. Usually the appeal goes to the CMH or it can go to the PHP depending. That's available because of the Medicaid money, which is federal dollars. Attached to those federal dollars is what's called, there was a lawsuit, actually a Supreme Court decision in the early 70s called Goldberg versus Kelly, which gave individuals the right to air their grievances with their government, i.e. appeal adverse determinations by an entity such as, let's say someone wanted food stamps and they were told they didn't qualify for food stamp. One of the things that the Goldberg versus Kelly decision gave was the right to challenge that. So that's why we now have, and this also applies to 14th Amendment, another amendment of the United States Constitution, but it's all about rights to due process. And that's why we have it. And so as an advocate, if you're not an attorney, we're talking about administrative processes, administrative complaints that you can file that you don't have to be an attorney to file. So things like appeals. And then if you don't like the decision at the appeal, let's say you or your loved one or your client is looking for, I'll just use 30 hours a week of community living supports, which is a service that helps people be more independent in the community, and the CMH or the PHP says, no, we really think you only need 15. You can appeal that. And then if they still say, no, we disagree, we think you only need 15, not 30, well, then you have a certain time you go and you request what's called a Medicaid fair hearing, which is through the State Office of Administrative Hearings. So that is why you need to know the funding. Now, if somebody is getting services for community mental health and they don't have Medicaid, they're not going to be able to use those processes because their services are not funded with Medicaid. They're funded probably with state general fund, and the person probably has an ability to pay. And that's a whole different process. So that's why knowing the funding and who's paying the bill is so vital, because a lot of these different laws are tied directly to the funding. I'll give you a good example. If anybody here is familiar with Section 504 of the Rehab Act of 1973, that only applies to entities that receive federal funding. So, Joe nonprofit that provides behavioral health services down the street that doesn't take any federal funding is not beholden to 504. Now, entities that take Medicaid and Medicare are beholden to 504, the Rehab Act. And so that's why it's important to know what is the source of the funding. And for people who get services that are funded with state general funds, they also do have some due process, but in my mind, it's limited. We'll talk about that later in this presentation. The different types of advocacy you can see here, maybe you're helping your loved one or your client access a social welfare program, food stamps, Medicaid, Social Security. Social Security has a whole process too, excuse me, for, if you are denied Social Security, there's an appeal that you can go through. You also might want to be helping your loved one or your client protect his or her rights in a system like community mental health. You might also, if the person's in the system, maybe something happens, maybe they're in an adult foster care home and they're not receiving top-notch quality treatment, or maybe there is unfortunately some abuse or neglect, you might have to think about, well, how do I help them preserve and protect their civil rights and maybe their welfare? So it's not just about getting services or maintaining services. It can be a lot of different issues that arise, especially when you have someone, a client or a loved one in the system. So what about individual advocacy in a program? That can be, maybe you help your loved one complain about a service or apply for a program. We talked about that. And what do you need to know in order to begin the process? And what do you and your loved one need to do in order to request services from a local CMH? So we're going to kind of transition in a moment from talking about the different types of advocacy to talking about an overview of the community mental health system in Michigan. And some of this, because you're going to get the entire slideshow, the slide deck, some of it, I don't want to be redundant. So some of it, I'm not going to spend a lot of time. But this kind of goes back to when you're working in a system as an advocate, it's really important that you understand the way the system is set up, how the system operates, and what you can expect from the system as well. Anyway, your overall role really is to be there to assist if there's a bump in the road. Also making sure that if you have a loved one, and of course, as a disability rights advocate, we always encourage the person themselves who is seeking services or navigating a system to speak for themselves. But if they're having a hard time doing that, then we make sure that the person, we help communicate with and on their behalf. Because, one thing that needs to be said, and I've heard this from a lot of families and individuals, the system is intimidating for people. The system is overly complicated, and a lot of times it can seem like there's more barriers that are erected to getting things done, and that it's not very easy to get from point A to point B. And I have to say that I don't disagree with that. For people, especially who are just getting used to the system, who don't know the system, some of it, I remember years ago thinking some of this stuff doesn't make any sense to me. And so I think those of us that are working with people who are not familiar with the way the system operates, we need to be prepared to educate people to the best that we can, explain to people why things are that they are without sounding, for me, it's important that I not sound like I'm apologizing, because I will not apologize for a system that's not doing its job. But being really empathetic and understanding about how difficult it is and things that we might know really well. And I have to watch this with myself because there's a lot of acronyms in this system. Being really aware of the fact that other people are not as familiar, and it takes time for them to get acquainted with how it all works. Let's talk about accessing services. Again, I already talked about this. Due process means helping your loved one, for example, or a client, if they've been denied services by the local CMH. And we're going to talk about this. There is a section of the Michigan Mental Health Code that we will talk about that really speaks to, what is the process available to somebody when their loved one or they or their client has been denied services by the local CMH. Again, due process is basically your opportunity to say to the government, because CMHs, for example, even though they are mental health authorities, most of them, not all, they are somewhat quasi-governmental. They're independent of the county to the extent that they operate as a separate entity, although for community mental health, there's 46. The members of the Community Mental Health Board, which statutorily, with the exception of Detroit Wayne, there are 12, it's the county commissioners of the county that appoint the members to the Community Mental Health Board. Excuse me. But you do have your opportunity to say to the government, I disagree with your decision. And so people do have a right to a second opinion, and we're going to talk about the process of requesting a second opinion a little bit later in this presentation. One thing I do want to say is that oftentimes I find when I get calls from individuals or families who were denied services, the CMH failed to tell the person or the family member or the loved one that they have a right to request a second opinion. So that's another reason why we like to do these educational webinars on a periodic basis, because we want, it's important to MHAM, it's important to me that individuals, family members, loved ones, friends, supporters, other professionals who are supporting people know that when a CMH says, no, you don't meet our eligibility requirements, that folks have the ability to say, well, wait a minute, then I want another person to do an assessment. I want another person to say yay or nay because I disagree with you. The other thing about the administrative process, I think I talked about this earlier, you don't have to be an attorney to provide representation to a loved one who's been denied. Denials of services aren't the only thing. There's denials, there's suspensions of services, there's reductions of services, there's termination of services. All those things have the administrative process to address those. And even though they are legal processes, it's not the same as providing representation in a court. Now, an administrative hearing, you go before an administrative law judge who's an attorney in this state. Other states, not so, but here we do that. But again, a person can represent themselves. They can represent themselves in a Medicaid fair hearing, a food stamp hearing. They can even represent themselves in a Social Security hearing if they want to. Not saying that they would want to, but they can do that. And they can also appoint somebody else to represent them if they don't feel comfortable doing it themselves. So a couple things, if you're, find that someone you care about or you yourself or your client has been denied something or a service has been terminated, suspended, reduced, you have to understand the program. You got to know how to build a case. You have to do some type of investigation, meaning getting documents so you can figure out whether or not your loved one does meet requirements or is eligible for services. You have to read, ask questions, and do research. And I have to say that I've educated a lot of families, especially about how to navigate these processes. And I'm always impressed with the level of sophistication that they develop in doing so. One of the things that does make it a lot easier than it was, say, 30 years ago to do advocacy when I first started doing it is the internet. You can go online and find for example, the Code of Federal Regulations. 42 CFR 438 is the section of the Code of Federal Regulations that applies to managed care at the federal level. And that is the Code of Federal Regulations, the title 42, 438 is the section that defines or discusses managed care in Michigan. You look up in there, you would see, and we'll start talking about CMH in a minute, but they define what is a prepaid inpatient health plan in the Code of Federal Regulations. So again, a lot to know. But one thing I do encourage folks, if you're going to work in the system or work with the system, meaning you're a person that maybe you contract with CMH or PHP, or you are a provider, or you have clients, loved ones, family members who navigate the system, knowing how it works, if that's a lot of the work that you do, is really important. So again, it can be very intimidating. You don't know. You might ask people and get the right answer. I've had the experience of getting the right answer. I've had the experience of getting the wrong answer from people who should have known. So that's when you just, you do your own research. And right now it's so much easier to do than it used to be. So one final word about activism. Social activism, which is showing up in whatever form you need, whether through letter writing, going to demonstrations, systems advocacy, where you're writing letters to legislators and policymakers, whatever that looks like for you, it's very important. And you don't have to participate in a rally to accomplish policy change. Letters are powerful. I remember about 4 years ago, a senator telling a group of us advocacy organizations that he said, don't send emails, either make phone calls or write letters or show up at their office, call their number ask to speak to the scheduler, and get a face-to-face meeting with people. So if there's an issue that you feel really strongly about, what I really recommend is, in this situation, going to Lansing, meeting with someone face-to-face. Another thing you can do if it's a local issue is, if it's a county issue, I recommend meeting with the county commissioners or your county commissioner of your district. If it's your city issue, there's your city council. The other thing you can do is, if, when it comes to like community mental health, if you're concerned about your local community mental health, you can also attend. Community mental health has, each board has a monthly meeting. And because they are subject to what's called the Open Meetings Act, and are considered a public body, they have, there's a law in Michigan, we call them sunshine laws, the Open Meetings Act. They have to be publishing when their meetings are. They give you access to agendas. And they also have to let you know about what's called public comment. You're allowed to make public comment at those board meetings. This applies not just to community mental health. This is like county commissioner meetings, city council meetings, any other kinds of commissions. So please be aware that those are your rights as an individual. You can call, I forgot to put the ARC Michigan's number in here, but you can call advocacy groups for assistance. Disability Rights Michigan is a really good one. And I will put the ARC Michigan. So now I'm going to do a brief overview of community mental health, just in some of the things that you can do if you're advocating in the system. Basically, community mental health came into existence for a couple reasons. One was, as I indicated earlier, we had over 500,000 people in state psychiatric hospitals across the country. The conditions were deteriorating, they were overcrowded, and as indicated earlier, we didn't really have treatment. A lot of the people that were in psychiatric hospitals had psychosis, and we did not have the first antipsychotic until 1952, when the French created Thorazine. Thorazine came to the United States in 1954, and a lot of what we call the older typical antipsychotics, Thorazine, Prolixin, Stelazine, Haldol, a lot of them were taken from that class of drugs, which was called phenothiazines. And so when that happened, when we had Thorazine, it was considered a miracle drug. And that meant that maybe we didn't have to house people in these sprawling, overcrowded institutions where people were literally sleeping on top. It was signed into law by John F. Kennedy on Halloween 1963. And of course, 3 weeks later, we all know he was assassinated in Dallas, Texas. The idea was really about deinstitutionalization. Now, what's interesting about this, the other thing I want to say really quickly is that we didn't have SSI or Social Security disability for folks in 1963. Remember, a lot of these programs didn't come into existence until after Kennedy was assassinated. And then we had Johnson became president, and he had his war on poverty. And that's why we ended up with an augmentation of food stamps, the Food Stamp Act of 1964, Medicare, Medicaid. Actually, supplemental security income, or SSI, didn't even come about till 1974. This comes out in 1963. We don't have Medicaid yet. We did have a Community Mental Health Act in Michigan before the Michigan Mental Health Code in 1974. A lot of times what happened was the states were responsible for providing care. So the initial plan for community care meant that you would create case management. And so what I want to say about community mental health is that originally community mental health was focused on getting people out of psychiatric hospitals and providing case management. And basically, case managers have a couple functions. One is linking, monitoring, and coordinating. I mean, when I was a case manager, I remember that's what I was told my job was. The whole goal, and you saw this in virtually every treatment plan, Joe will remain psychiatrically stable for 12 months. Here's all the objectives Joe needs to meet to stay out of the psych hospital. That was like the big goal. Um, of course, by the time the 70s and the 80s arrive, we find out, well, people need housing. No, they can't always stay with family, which is what typically happened. You know, we had a lack of housing. I mean, the housing problem is even worse now, but we didn't have enough subsidized housing because who can afford to rent an apartment when they have no money or when the SSI benefit is so low? Substance use dependence. There's a lot of different reasons why, you know, when we developed the community care model or the case management model, it was very successful, but a case manager is only as good as the resources that they have available in the community. So sorry, I don't know why that is so light. Um, so basically, we had this civil commitment case. It was May 1974. There was a law. There was declared unconstitutional. Was Bell versus Wayne County General Hospital, and so then a lot of procedures about involuntary commitment were changed. Basically, in 1974, when we had the creation of the mental health code. Why this is doing this. I am so sorry. In 1974 is when we actually had people started getting really rights in the mental health system. So that was the other thing that to talk about is that, and it's not the subject of this particular presentation. I've done presentations on the history of psychiatry, but people with mental illness typically didn't have a lot of rights. In state psychiatric hospitals or even in community hospitals. So in Michigan, we had the Community Mental Health Act of 1963. Then, of course, the Social Security Act of 1965. And then, of course, Michigan passed its own version of the Community Mental Health Act. Then in 1974, Act 258, which is what created the community mental health boards. And it was an effort to take all the laws, statutes regarding mental health and put them all under one roof, which is what Act 258 of 1974, what we call the Mental Health Code, refers to. So just briefly, broadly speaking, if you're interested in this, if you want to understand how a community mental health is set up, or even, you go look at Chapter 2 of the Mental Health Code, and it really outlines what a community mental health service provider, which is what we call them now, it outlines in very clear terms what their rights and responsibilities are. And again, the focus is about no longer putting people in institutions and keeping them in the community. In 1981 is when what was called the Department of Mental Health created shared full management contracts with all the community mental health service providers. At that time, I think we had 49. And shared management simply meant that they would take full responsible for administering mental health services in their area. So the state would give them the money, and anybody in their county or counties that met criteria, they would be responsible for. And previous to that, the state was fully responsible. And so this shifted responsibility to the CMHs from the Michigan Department of Mental Health. Yes, they were given more money, but they were also assuming more responsibility. So for a long time, CMHs had to pay for, so anybody that from their county, their service area that went into a state psychiatric hospital, CMHs were responsible for paying for that person's stay in the state hospital out of their general fund. That changed in 2014, but that's the way that it used to be. So there was a lot of pressure on CMHs to keep people out of hospitals. This talks about substance use disorder treatment. We created what's called coordinating agencies in 1978, but then in 2012, we had the Pulaski bill, which required all the substance use disorder coordinating agencies to merge with the PIHPs. Right now, we have 10 PIHPs in the state. For children with serious emotional disturbance in 1956, Hawthorne Center was open in Northville. MHAM, Mental Health Association of Michigan, had a huge role to play in that. Then in the 80s, we were starting to move away from institutionalization. And that's when the idea came that maybe we could serve kids with SED in the community. Till the early 70s, we had a variety of child caring institutions that provided residential treatment. But then restraint and seclusion rules were changed in the early 2000s, and many child caring institutions were unwilling to contract with CMHS to provide care. A lot of that had to do with restraint and seclusion. And I want to say MHAM is not a proponent of restraining children and adolescents or putting them in seclusion. But what I will say is that for any entity that provides care to these children or adolescents with severe behavioral health issues, there has to be some way of keeping the child or the adolescent safe from him or herself, but also other people potentially safe from the child or the adolescent, because there can be significant acting out behaviors with these young people. Problems that we have right now associated with the lack of residential treatment for children with SED is that a lot of these kids find themselves cycling in and out of the juvenile justice system or community inpatient because we don't have long-term residential anymore. CMHs are the providers of what's called home and community-based services intended to reduce the need for residential. And in 2023, the MDHHS created the Bureau of Children's Coordinated Health Policy and Supports with an ombudsman's office. And in 2018, we had MDHHS was sued by Disability Rights Michigan and other attorneys in a case called KB versus Lyon, which has been settled. And we're still waiting to hear the detail on what's called My Kids Now. So moving toward a continuum of care for children with serious emotional disturbance includes, outpatient treatment, specialized services, specialized residential, and now we have what's called PRTFs and residential treatment. So again, not sure what's going on with this slide, but how is community mental health funded? Just so you know, if you're going to advocate in the system, right now, community mental health is like 95% Medicaid funded. They do have some state general fund dollars, but in 2014, when the state general fund was cut by 65% to the CMHs, a lot of them declared themselves to be Medicaid only. General fund is for people that don't qualify for Medicaid. What that means is that if somebody is eligible under the mental health code, which means they have a serious and persistent condition as defined by the code, and they are eligible for services. If they have Medicaid, they cannot be placed on a waiting list. But if the person doesn't have Medicaid, but they are deemed eligible for services, the mental health code says that the person can be placed on a waiting list for services. And the state is supposed to be monitoring the waiting lists for people who are on the list because of state general. And, from a historical perspective, before we got to the place where we are now with managed care, there was a time when CMHs and others became Medicaid fee-for-service provider under a sole source contract with the Michigan Department of Community Health. And that existed up until the time we developed managed care, which was in the late 90s, early 2000s. The problem that happened in 2014 was that because a lot of children with serious emotional disturbance, their families don't meet criteria for Medicaid, but when you have general fund and you're eligible for services, you do have what's called an ability to pay. A lot of children with serious emotional disturbance and a lot of adults with serious mental health conditions were discharged from CMH services due to not having Medicaid, or adults with serious mental health conditions had a large, what's called the Medicaid spend down, or now I think they call it a deductible. General fund has been used historically to meet spend downs. And so a lot of people lost their services during that. So in 1998 is when Michigan decided to adopt the PIHP, the managed care model. And that model has been a blessing and a curse. So basically, real quickly, Medicaid managed care is the idea that you have a large population of people in your service area, and those who have less significant conditions will typically use services less, and then you'll have a percentage of individuals who are much higher need, who will use more services, and it will balance out. The challenge in public mental health is that community mental health typically serves people with the most severe conditions. I mean, that is who ends up going to community mental health. In some respects, I think managed care has been a good thing, but in many ways, it's not been such a good thing because there's a lot of disincentives for PIHPs and CMHs to provide services, because the way it works, and I really want to clarify this because families ask me this a lot. They're like, well, aren't they getting rich off of my loved one who's getting all these services? And the answer is no. The way the state figures out the funding, they work with an actuary named Milliman who goes through a process. And there's this mysterious, interesting element called the geographic factor. And literally, when you hear per capita, capita in Latin is head, each person with Medicaid is basically put into what's called a rate cell, where they try to determine what is it going to, based on some factors, what is it going to cost to serve this person per month. That's the way it works. So CMHs get their money from the PIHP, unless they're Wayne, Oakland, Macomb are both a PIHP and a CMH. But the 7 multi-counties get their money on a monthly basis, their allotment. And one thing to know about Medicaid is that when times are good and there are less people on Medicaid, the CMH system is going to have less funding because their funding goes up and down based on the number of people with Medicaid in their region or in their county. So if there's a lot of people on Medicaid, they get more money. If there's people that are doing well, getting private insurance, getting good jobs, no longer needing Medicaid, their revenue goes down. And they get money from anybody with Medicaid, even people who have temporary needy families or TANF Medicaid, Healthy Michigan Medicaid. They get a payment, but it's a much smaller payment. Mostly what funds them is what's called disabled, aged, and blind Medicaid, or I hate to use the term, but DABS Medicaid. It's important to know that. We started to transition people to managed care. Then we created what's called the behavioral health carve-out, just so you know what that means. Means that only community mental health and the PIHPs in Michigan can access dollars that are set aside for the community mental health systems. No other entity, health plans cannot access CMH dollars. Only CMHs and PIHPs, which are comprised of CMHs, can access those dollars. And back then, if you wanted to be a PIHP, you had to have at least 20,000 Medicaid covered lives. Here's the definition of a PIHP, or prepaid inpatient health plan. The other thing I want to say is that the PIHPs in the state have what's called a shared risk arrangement, meaning that if the PIHP overspends after a certain point, the state has to bail them out. It's called the risk corridor. It's a really complicated formula. Not something I ever fully understood, even when I was a CMH director. It's pretty complicated, but it is a shared risk or a comprehensive risk arrangement. not a it's a shared risk. What is a Medicaid waiver? A Medicaid waiver simply means that it waives certain requirements. It allows the state to do really creative things with Medicaid money. We now have what's called, forgot to put the 1915 C waiver, which is the children with the SED waiver, the HAB waiver. We have a 1915 I waiver. They allow the states to do creative things with the dollars. One of the things we have in Michigan is what's called home and community-based services waivers, which include special services like community living supports, which allow people to be more independent, respite for families so that they can get a break from caregiving, family support and training, excuse me. It's a whole list of services that people can get through the home and community-based services. The CMHs and the PHPs provide the oversight of long-term care for people with severe mental health conditions and intellectual developmental disabilities. And this is just a little bit more the information. I guess the thing I would say is that the whole point of these waivers was to get people out of institutions, especially things like what's called the Habilitation Supports Waiver, the SED waiver, the My Choice waiver, which is for people with disabilities who would otherwise be in nursing facilities. The whole point is to give them services in the home so that they don't have to be in institutions. That was really the point of home and community-based settings. Originally, we had 18, and then in 2013, 2014, we went to 10. They all formed under the regional entity statute. We got what was called an application for participation. There was no guidance on what the board structure should look like. There was none of that. And we had a very short period of time with which to try to put together a board of directors, choose the CEO of the PIHP, choose a chief financial officer, information officer. There were certain C staff that had to be chosen. One thing that is important for anybody advocating in the system to know is that I focus on provider network services because one of the problems I hear a lot about from families and from individuals is they ask for service and they're told, well, we can't put the service in the plan, or we can't give the service to you because we don't have a provider. Have had many conversations with the state about this. The CMH cannot deny putting medically necessary service in the plan because they don't have a provider. The other thing that is been challenging for people, especially providers, is that providers, if they contract with more than one or two CMHs in the state, you might hear them talk about is how difficult that is for them, because one CMH or county may do things one way and another one will do things another way. And when it comes to credentialing, we do have in statute now that there's supposed to be universal credentialing, but there have not been rules written regarding that yet. But this is a map of the current PIHP regions. Basically, the PIHPs, their job is two things. One is they write the checks to the CMHs. And the other thing is they're supposed to be making sure that the CMHs follow the rules and spend the money accordingly. The providers are the CMHs themselves. And the PIHPs they get a monthly capitated payment from the Michigan Department of Health and Human Services. And then, of course, they do issue Medicaid payments to CMHs or PIHPs issue payments sometimes to other community providers, but mainly PIHPs pay the CMHs. Right now, unless there's arrangements I'm not sure that I don't know of, CMHs typically pay for their own inpatient psychiatric hospital bills. Actually the mental health code talks a lot about CMHs as being the only ones that can authorize inpatient right now. That would be in chapter 4 of the code when they talk about pre-admission screening, and also in chapter 2 of the code. Okay. PHPs are supposed to be holding CMHs accountable too. And one of the things that us advocates have talked a lot about is the fact that that's not really possible when you look at the way that the board of directors of the PIHPs are configured. And I've been told by people in the system there's no conflict of interest, but I don't know how there cannot be a conflict of interest if the members of the PIHP have their own CMH board members on the PIHP board. I don't know how that's not a conflict of interest. So it means that accountability and oversight is something that the advocates have been very concerned about for a very long time. What's interesting about Wayne, Oakland, and Macomb is that their same board is the CMH board, and it's also the PIHP board. They're the same people. So, because we're running out of time, I just want to say, if you want to know what the CMH does, because you got to serve somebody, this is a section of the mental health code, and it's really easy to find the code online, but these are the services that CMHs are supposed to provide. These are their main services. So basically, crisis stabilization, response, assessment, identification, assessment, diagnosis. By the way, when a CMH gets a call from a hospital that they need to assess somebody, because right now, the way it works, anybody with Medicaid, anybody with no insurance, the hospital is going to call the CMH. So even if somebody has McLaren Health Plan is their health plan and they have Medicaid, it doesn't matter, because today, at least right now, on March 26, 2026, the CMH will pay the bill, not the health plan. Now, there's some talk that that could change through this mental health framework. We've expressed a lot of concerns about the model of it, but that's the way it is right now. Also, it talks about, planning, linking, coordinating, follow-up, specialized mental health recipient training and support, recipient rights services, which is what CMH does, mental health advocacy. CMHs were using general fund to provide additional support and community-like prevention, what they call community benefit, which with the general fund being so significantly reduced, they haven't really been able to do that. Any other service approved by the department. And then, as it says here, services are supposed to promote the best interests of the individual. Each PIHP must give a recipient of services a copy of its customer service handbook. If you want to see a really good one, you go look at Southwest Michigan Behavioral Health. The state does have a template that the PIHPs are supposed to use for their customer service handbook, by the way. Other reference documents are the Medicaid provider manual. Somebody is seeking services from a CMH, and I talked about this a little bit earlier.